Hi, I'm Melissa York.
And I'm Rachel. We're going to go ahead and talk to you all about DVTs today, or deep vein thrombosis. So during our presentation, we're going to try and go ahead and give you a quick clinical overview of what deep vein thrombosis are. We're going to go ahead and talk through some of the pathophysiology, risk factors, as well as diagnostic tests and treatment, and nursing interventions and patient education. Throughout the presentation, we'll also integrate in some current scientific studies that we've found from nursing articles that have current research on DVTs. So to start, we'll go ahead and go through the overview, which is here in the center of our poster board. So DVTs and pulmonary embolisms are components of what we call thromboembolisms. So sometimes when you hear the word thromboembolism, those are referring to either a deep vein thrombosis or a PE, pulmonary embolism. Also, DVTs can sometimes be provoked or unprovoked. So that means that there may be an incident that brings on the circumstances for a DVT to occur. Other times, the reason for a DVT forming may or may not be known because there's nothing that precipitates it. Another thing that's interesting to note for DVTs are that they're typically in your distal area, such as your calves or your lower extremities, but they also can occur other places in your body, such as your upper extremities as well. So DVTs can be symptomatic or asymptomatic, which Alyssa will get into a little bit further, but we just want to go ahead and give you a quick overview of DVTs. There's a nice summary picture here that is kind of a quick glance at DVTs. It talks about the incidences of DVTs, so the incident rate. In the U.S., about 900,000 people typically have a DVT or PE, and 100,000 of those people in the U.S. Can actually have fatal outcomes from a DVT or PE. It also talks about some risk factors and signs, which we'll talk about later, but this is a quick overview capture of DVTs. So getting into that pathophysiology a little bit, basically you have some sort of injury or insult to your blood vessels. That then kind of starts the process of a cascade of white blood cells and platelets that go to that area of injury, and they actually kind of adhere and create a clot. Those clots can be partially occlusive or they can be fully occlusive, which would actually then block any sort of blood flow distal to the area. Or like Alyssa will talk about a little bit later on with PEs, those DVTs can break off and go other places in your body. So here's an image that shows the blood vessels. It talks a little bit about the different layers of the blood vessels and kind of shows that process of injury to the blood vessel starting that cascade process. There's a triangle up here that talks about some of the risk factors for DVTs. It's also referred to often as Virchow's triangle. It's referenced in several studies as that, as well as Lippincott Advisor and other sources and textbooks. So there's three kind of common risk factors for DVTs. The first one is a hypercoagulable state. That typically means that you're already at risk for having those clotting factors at a higher rate, such as with pregnancy, you're in a hypercoagulable state, or sometimes with malignancies such as cancer and things like that. There's also the risk factor of circulatory stasis, meaning you already kind of have reduced blood flow, and so you have more just kind of sitting in your veins that are pooling, and so that's common in people with bed rest or paralysis or things like that. And then the third part of the triangle is vascular wall injury, and that would be after surgery or trauma or something that kind of provokes that insult to that area of the vein, kind of starting the process of deep vein thrombosis. So in the clinical setting, there are lots of different tools that they use to kind of identify patients that are at risk for DVTs. One of them is the Wells prediction rule, and there's actually a study that was done by Rosa Jimenez et al. In 2015. They basically looked at all these different clinical prediction rules, and they found that the Wells prediction rule actually was most effective at predicting whether or not someone was at risk for a DVT, and it also had a false negative rate under 2%, which was really great for studies. The actual Wells prediction rule goes through different categories, such as is this person at risk for cancer? Do they, by chance, have already blood stasis? Do they have legs swollen? And it gives them a point for all these different categories, and then it rates their risk for a DVT based on their score. So a score of 3 or greater would put them at high risk.
And so now we're going to get into our assessment findings and your nursing interventions and patient education. And so with our assessment findings, we have a study called DVT Treatment and Diagnosis, and in that study they talk about some of the things that you would find in your nursing assessment that would show you signs of a DVT. And so, like we referred to earlier, there are some DVTs that are asymptomatic and that show no signs, but one way to slightly test a potential DVT in patients, as they often do this in postpartum floors with new moms, is the Holman sign, which is where you have pain on dorsiflexion of the calf, but this is also not a very reliable indication of a DVT, but it's an easy and quick way to test. But you can also look for any patient complaint of pain or redness or swelling in one calf, not both. A DVT is going to be unilateral on one side only, and any type of like palpable cord-like feeling when you're palpating the patient's calf, which would be a sign of that clot in the vein, or any type of superficial venous dilation or any warmth, and also any cyanosis from below in the lower extremity. And that same study also talks through some of the diagnostic testing that you can do. And so one of the tests that they would do to rule out a DVT would be the D-dimer test, which just tests for proteins found when an embolism is formed. So then you can also do coagulation studies like your PTT and your INR to check your patients to see if they're in a hypercoagulable state just naturally. And then for a more sure test, you're going to look at your compression ultrasonography, which you're going to use to find the vein and the exact location of the DVT. And if you suspect that your patient's DVT has progressed to a pulmonary embolism, you always want to get a chest X-ray or CT scan to find that and confirm that, because that is a life-threatening diagnosis. And then for our treatment, we have another study that talks about the non-pharmacological treatments and this also goes with nursing interventions, with non-pharmacological treatments and approaches to treating a DVT. And so that is going to include your anti-embolism stockings or your pneumatic compression devices, and also just ambulation and keeping your patient from having venous stasis. But you're also going to want to elevate that extremity, and you're going to use, make sure that they are not like, you want them on bed rest but with some ambulation just to keep blood flowing in their extremities, or having a pneumatic compression device to help keep blood flowing. And then you also are going to use medications such as Lovenox, heparin, warfarin, or even aspirin to help with that, reduce their coagulation state and keep their blood thinning. And for patients, surgery is sometimes needed to treat depending on the extent of the DVT and the blockage. And so for our nursing interventions up here, we are going to look at, again, using those compression stockings and your anti-embolism stockings and your pneumatic compression devices, administering any of those anticoagulants to your patient regularly, and also just helping keeping your patients doing any sort of range of motion, moving their extremities and preventing venous stasis. You're also going to want to continually assess your patient, make sure that their redness, warmth, swelling is going down in their extremity, comparing it to the unaffected extremity, and assessing your patient for any signs of a pulmonary embolism or any movement of the DVT causing any other serious issue. And so one other study that we found, which is bed rest versus early ambulation, shows that while for a long time literature stated that, in practice showed that you should have patients with a DVT on bed rest to prevent the movement of the clot, that it's actually more helpful and has better outcomes for the patients to have early ambulation, and that patients with early ambulation actually don't show signs of complications such as a pulmonary embolism any more than a patient on bed rest would. And then for patient education, we just want to do we have one comment for patients that would be at high risk for DVTs, which is going to be any immobile or stroke patients, or a large populations of patients that develop DVTs. And for that type of patient, you would want to educate them that, like this one study found, that pneumatic compression devices are the best treatment, especially in hospital, and that your anti-embolism stockings are less effective than that for a completely immobile patient. But for the rest of your patient education after DVT and continuing to prevent DVTs, you're going to want to teach them about self-administering their medication. You're going to want to teach them about any bleeding precautions that they're going to need to be on, or any dietary restrictions that they're going to have due to their anticoagulant therapy. So anything about greens, or using soft bristle toothbrush, and how to look for signs of bleeding and when to contact their provider. And then you're also going to want to teach them how to use their anti-embolism stockings and how to correctly put them on and ensure that they're on, and make sure that they're putting them on in the morning and taking them off at night, giving their legs time to breathe and preventing any ulcers or skin issues. And so with that, we have a chart right here that is showing this wheel that is showing a patient how to put on an anti-embolism stocking, because it can be a difficult task at first. And so you're going to want to start by taking your anti-embolism stocking, as Rachel has right here, and you're going to take it and flip the top down until you can reach the toe, so that you're able to adequately get your foot in. So you're going to pull it all the way down, just like this, and so that way you have room to work it up your calf. And so then you would, next you're going to place your toes in and pull it up over your heel. And so she's going to show with her hand. And so you want to then start working the stocking up your calf until it reaches your knee or your thigh, depending on the length of your stocking. And that would have your stocking all the way on. And so to take off your stocking, you're going to start by taking the top of your stocking and rolling it down, and then just doing the opposite of what we did, and then pulling it off, and then you have your stocking off. And so one important note with your anti-embolism stockings is that you want them to be smooth and flat against the skin to prevent any impeding of blood flow. So we thank you for your time, and we hope that you've learned a little bit about deep vein thrombosis and treatment and current research.